When Bernard asked me to talk today, I was obviously honored to come. It's a great meeting and honored to talk about our work. Although I guess if Bernard asked me to wash his car, I'd probably be honored. He's one of my heroes. Well, you know, I look up to him. Maybe others don't. But when I saw the title of my talk and the question mark, the ultimate ambition, I sort of got the sense that maybe Bernard was trying to send me a message that maybe our work, maybe we should wrap it up, maybe we should move on to other things. But I hope to convince you that what we're doing is interesting and hopefully useful as we develop even more effective immune therapies for kidney cancer. So as many have described at this meeting, our goal has been to try to improve the therapeutic index of IL-2 as we are with all of these agents by coming up with predictive biomarkers to hopefully prevent patients who are not going to respond from receiving the drug. And as Dr. Ito described earlier, we did perform a prospective trial. I think this trial had some positive points. This is the first one. It showed that the activity of the drug in the era of targeted therapy is actually significantly better than it was 20 years ago when the drug got approved. So our response rate for the trial was 25%. This isn't because IL-2 is any better than it was 20 years ago. It probably is because we're getting better at selecting patients for getting IL-2. Those selection criteria probably have to do with the fact that we're not treating as many patients with non-clear cell histology, the fewer patients being treated with their primary tumors in place, and obviously these newer agents that are available are trying changing referral patterns. But we clearly have seen an improvement in our outcomes in the U.S. There were some other interesting correlates. We had thought that non-clear cell patients were not responding. A small number of patients with non-clear cell were treated on this trial. We didn't see any responses. Those patients probably should not receive high-dose IL-2. Same can be said for those patients with a poor risk UCLA SANI score. We didn't see any responders in that group as well. And when you looked at the overall survival for the patients with a high-risk SANI score, those patients also did poorly as it relates to survival, and that's probably another group that probably shouldn't receive high-dose interleukin-2. Interestingly, this is the survival curve for the cohort of 120 patients. I think what this suggests, you could argue, is just a very well-selected population, although the percentage of patients with intermediate and poor risk in this trial was quite similar to those in large phase 3 settings. But more importantly, I think this suggests that you can try immunotherapy first, particularly in the setting of a clinical trial, without affecting overall survival outcomes. So it's not necessarily advocating for IL-2 first, but it's a suggestion that you can give IL-2 and then salvage many of the failures with standard agents and produce significant improvements in overall survival. But the goal of the trial was not to show that IL-2 was better than it was 20 years ago. It was to try to improve our selection criteria looking at tumor-based prediction models which combined histology and CA9 score into two risk groups, both good and poor risk groups. And unfortunately, or fortunately, from the patient's perspective, our assumptions about who was poor risk when we started the trial, it turned out we couldn't confirm them, meaning the folks who had what we thought was a poor risk tumor histology, a CA9 score that was low, or the combination, actually did just as well as those patients we thought were in good risk categories. And this sort of drives home the point of how we need to do well-designed prospective trials before we take any biomarker as a standard. Interestingly, CA9 had been used so many times in retrospective analyses that it actually got into our literature for the oncology review boards as a predictor for IL-2 response. This just goes to show you, how things can sort of get out of control a little bit. So potential explanations for this somewhat disappointing result as CA9 is it may be that there are tumor factors that do predict for the response to IL-2. There's got to be some explanation for why some patients are cured of their disease with this agent, but maybe other factors besides CA9 are more predictive. As we've heard earlier in this meeting, there was some concern on our part that the samples we analyzed were not representative, given the fact that there was a lack of standards of tumor processing at community centers. This point was sort of driven home in the recent New England Journal paper that's been mentioned several times at this meeting. Another factor that we're really starting to focus on a lot, and we have some evidence that this may also play more of a role in determining response to immunotherapy in general, is it may be that host factors like the patient immune response or the tumor microenvironment, as we heard about yesterday in two very good talks, may play a larger role in determining response to immunotherapy in general. This is something that Tom Gajewski has talked about in several places, including this review recently from last year, that there's a sense that there may be two different classes of tumor types. This sort of non-inflamed phenotype, where there's a high expression of vascular markers in the tumor, lots of macrophages and fibroblasts, low inflammation, low production of chemokines, few lymphocytes, with poor effector cell trafficking. That is what he describes as a non-inflamed situation. And then there might be tumors that are sort of what he calls an inflamed phenotype, where there's high levels of innate immune signals, lots of chemokines that are recruiting T cells. So you see lots of T cells in the tumor, but also production of these negative regulatory signals. So we've tried to take a look at a few of these. I'll just talk about the work with PD-L1, which is one of the stronger negative regulators of the immune response to cancer. This was looked at in the setting of a PD-1 antibody in the trial that was just mentioned about Julie Bramer, the original phase 1 for the PD-1 antibody from Bristol-Myers. And in this very small group of patients, tumors that stained positive for PD-L1 expression actually were much more likely to respond to a PD-1 antibody. At ASCO this year, we'll see a lot more data on this subject. And the question will become, is a PD-L1 expression a potential marker for response to a PD-1 antibody? We're still early on, and it's probably too early to say that it is a marker, but at least it's a suggestion that maybe the inflammation that the tumors are experiencing may be a sort of proof of concept that this is an important phenotype to focus on. We decided to look at this expression in the context of IL-2 response and found something that we thought was interesting, that patients also, in the context of IL-2, in part of the IL-2 SELECT trial, if you were expressing PD-L1 or PD-L3 on your tumor, you're also more likely to respond to IL-2. But clearly more confirmatory work needs to be done on this. You'll hear a lot more about this in the context of this phase 1 trial, which this trial was over 300 patients. It's quite a large trial, but in just the context of the patients on the trial who had kidney cancer, we saw some interesting results in the sense that we saw patients who had failed prior therapies, in this case a patient with IL-2 and Sutent, who had a major response to a PD-1 blocking antibody. Interestingly, this response started relatively early after just 2 cycles of treatment and is now ongoing for 2 years and off treatment. So we're seeing durable benefit with an immune therapy in the context of far less toxicity than we see with IL-2. Obviously, quite a very small number of patients, only 16 patients reported. At ASCO, there'll be an update on this information that doubles the number of patients focused on. But we see responses in about 1/3 of patients thus far. And this is a look at the spider plot for the original 16 patients on this trial. And what you notice is that if you are achieving a durable response, often it's durable for up to a year. But interestingly, these patients have been on treatment during this time. So it'll be interesting to see when we stop the drug, these patients continue to have a response like we see with interleukin-2 and ipilimumab. So where are we in the selection process? Well, obviously CA9, we were unable to confirm that it's a marker for IL-2 response, but it may turn out that this inflamed phenotype, as I talked about with PD-L1 expression, may be associated with a response, but we need to confirm this work. Efforts to confirm other markers are ongoing in the context of other collaborations with other investigators, looking at things like KIR ligand mismatch, which I didn't have time to talk about, or HLA-DQ alpha expression in the tumor that may predict for this sort of inflamed response, we hope will predict for response to IL-2 and other therapies. But most importantly, now that we have more interesting therapies that are easier to give, I think this work, it makes sense to continue these efforts because it may allow us to refine the way we give these newer targeted agents for our patients with kidney cancer. So for those who say, is there a role for immunotherapy in kidney cancer, I would say there's been a lot of progress in the field over the last 30 years. Immunotherapy immunotherapy can be targeted, and this inflamed phenotype can be identified, and it might be a potential way of selecting patients for immunotherapy. And it's worth preserving because of curves like this, which is the response duration curve for the IL-2 SELECT trial, where you see patients in response, and 13% of them are durable over 2 years. That's reaching the patient's goal of treatment, remission, and then no treatment. We should focus as much on that so we can achieve Dr. Gore's dream of more cures for kidney cancer. Thank you very much for your attention.